How are you doing, guys? We're back with another video. Today's topic is ischemic heart disease. So what is ischemic heart disease? Ischemic heart disease is decreased blood supply to the myocardium, usually due to narrowing of the coronary arteries. And this causes something called supply-demand mismatch. So what causes the narrowing in ischemic heart disease? What usually causes the narrowing is atherosclerosis. And as you may know, atherosclerosis has a lot of risk factors, including hypertension, diabetes mellitus, dyslipidemia, family history, and age. And by the way, the single most important modifiable risk factor for coronary artery disease and ischemic heart disease on USMLE exams is smoking, and this is a high yield point. So, what is atherosclerosis? I'm not going to dive deep into the pathophysics behind atherosclerosis, but essentially what happens is there is some form of endothelial dysfunction, which leads to macrophage involvement, and this macrophages phagocytose LDL, and in turn turn into foam cells, which release growth factors, which leads to fibrous proliferation and narrowing and thickening of the affected artery. Um, and this plaque or atherosclerotic plaque is covered by a cap. Sometimes this cap rupture, as shown in this figure, and the rupture causes thrombus propagation or formation on top of this plaque, which causes acute on top of chronic obstruction. So, what is the presentation of ischemic heart disease in general? Generally, it's squeezing substernal chest pain that may radiate to the left arm or jaw, precipitated by exertion and relieved by rest. So here we come to the classification. So we classify ischemic heart disease according to the pathology behind each of those categories. I'll start by explaining the kinder form of ischemic heart disease, which is considered a chronic form, which is called stable angina. The problem in stable angina is atherosclerosis. The atherosclerosis in the coronary artery is severe enough to cause symptoms, but there is no plaque rupture. By the way, the vessel may be atherosclerotic but asymptomatic, and symptoms usually appear when 70% or more of the artery is narrowed. So, how does it present stable angina? So I will be sitting on the couch, relaxing, watching TV, sleeping. I will have no symptoms. But when I run, when I walk, when I maybe eat a heavy meal, I will have symptoms because my demand has increased. But the narrowed artery cannot supply the increased demand. So there is this thing called the supply-demand mismatch in stable angina. It's a chronic form, it's not acute. It's relieved by rest and nitrates exacerbated by exertion. And we'll go to the another category of ischemic heart disease, which is acute coronary syndrome, which is hence the name acute. The problem here is plaque rupture. If the plaque ruptures and there is no occlusion or no thrombus propagation or formation, this is with what we call unstable angina. And the differentiation point between unstable angina and stable angina is that unstable angina is usually acute in onset, and it is present at rest, in contrast to stable angina, which is not present at rest, it is relieved by rest. And in myocardial infarction, what happens is the plaque ruptures and there is thrombus formation and propagation, which occludes completely. It occludes the artery completely or partially. If it occludes the artery completely, so there is no blood flow to the myocardium, so there is death. And there is death of the whole thickness of the myocardium, and this is what we call STEMI or ST elevation myocardial infarction. This is a complete occlusion. If a partial occlusion happens, we call it non-STEMI or non-ST elevation myocardial infarction, in which only part of the myocardium is affected, which is usually the deeper part of the myocardium, which is called the subendocardial part. So this is a high-yield photo of an ECG for an inferior wall STEMI. As you see, elevations in leads 2, 3, and AVF. So how do we manage ischemic heart disease? According to the categories, if we're talking about angina, stable angina, Most importantly, we have to modify the risk factors like hypertension, diabetes mellitus, dyslipidemia, etc. Maybe take nitrates to relieve the symptoms, and also maybe take beta blockers because it decreases the contractility and decreases the demand on the heart. For acute coronary syndrome, this is the patient who's coming to the ER with acute sudden onset excruciating chest pain. First thing is first, I should do an ECG and troponin level, which is a cardiac enzyme inside myocardiocystes. And accordingly, I will manage. If this is a case of STEMI, I need to do an urgent reperfusion. If this is a case of unstable angina or non-STEMI, I will admit the patient and see if he's a candidate for angiography. Regarding drugs, I've admitted the patient, I've done his ECG. I need to give any patient with acute coronary syndrome those drugs. So I need to give them nitrates and beta blockers. But for nitrates and beta blockers, there are some contraindications. Nitrates are contraindicated in cases of right ventricular infarction. Why? Because nitrates causes venodilatation and decreases the preload that is getting into the right ventricle. And in right ventricular infarction, the cardiac output is dependent on the preload. So I've decreased it. So it may cause cardiogenic shock. And in beta blockers is contraindicated in cardiogenic shock because it decreases the contractility. However, for antiplatelets, we give dual antiplatelet therapy, and this is a high yield point. We give dual antiplatelet therapy, not monotherapy, because evidence has showed that it improves mortality. Also, we give high intensity statins because evidence has showed that it decreases mortality. And we give anticoagulation to decrease the thrombus propagation in the form of heparin or newer anticoagulant oral anticoagulant drugs. If the patient is STEMI, as we said, we will do reperfusion within 90 minutes. If reperfusion is not available within 90 minutes, we will do thrombolysis. If the patient is non-STEMI or unstable angina, we'll admit and see if he's a candidate for angiography. This is a case. A 62-year-old man presents to the emergency department sudden onset severe chest pain for the past 45 minutes. The pain is crushing, substernal, radiates to his left arm, and is associated with diaphoresis and nausea. He has a history of hypertension, hyperlipidemia, and smoking. Vitals are 1, blood pressure 110/70, heart rate 105, respiratory rate 22, oxygen saturation is 95. Patient appears anxious and diaphoretic, lungs are clear, heart sounds are normal, ST segment elevation in leads 2, 3, and AVF. Troponin 1 is elevated. What is the underlying mechanism of this patient's condition? What do you think? Thank you.